Hi, everyone, and welcome to the Vascular Spotlight, a partnership between The Way to My Heart and vascularcures.org. This week, we are focusing on the toe and flow model for limb preservation. We have with us Dr. Alex Reyzelman. He is co-director of the UCSF Limb Preservation Center and Diabetic Foot. So let's talk about the importance of this toe and flow model and what it means. It's one thing for a patient to get blood flow restored to their foot for those with peripheral artery disease, which is plaque buildup in mainly the leg arteries, but ultimately the peripherals. And then it's another thing to, if they do have a diabetic wound or non-healing ulcer on their foot, to also have that end of their medical therapy taken care of as well, because debridement is important to wound healing.
Correct. I think we realized several years ago that the only way to really save feet and to keep the feet on patients is to have a multidisciplinary approach and a collaborative approach between vascular surgery and podiatry. As you said, vascular surgery improves blood flow. We say that, they're the plumbers, right? They improve blood flow to the foot. However, once they do that, the rest is up to us. So once there's more blood flow to the foot and there's better perfusion, we then have to make sure that the foot stays on the leg. And that means by taking care of their ulcers, possibly taking them for debridement, making sure they have appropriate shoe inserts, shoes, orthotics, bracing, whatnot. And of course, surveillance is key because all of these patients are at risk. And even after we save their foot, we have to make sure that we follow them so they don't have a recurrence.
Right. There are new technologies such as what Podiatrics is offering. I know Podiatrics was a key highlighted innovation in your most recent innovation contest at UCSF. And it's a technology, it's a foot pad where it would sense whether or not diabetic ulcers are actually developing before they even break through the skin.
That's correct. Podiatrics has a mat-like scale, if you will, that measures temperature. And we all know that before wounds break open in the feet in the diabetic patients, there's elevated temperature. So if we can pick up temperature ahead of time or elevation in temperature ahead of time, we can potentially prevent foot ulcers from occurring and make sure we intervene earlier than later.
And this is temperature because most diabetic patients with peripheral artery disease, the circulation issues, they complain of cold feet. So is this something that is deeper within the foot in terms of a temperature increase, or is this something that they can even feel with their fingers temporarily?
No, it's really very difficult to feel with their fingers. And because they have peripheral neuropathy, which is inability to feel and sense in the bottom of their foot, that's really what gets diabetic patients in trouble. They're unable to feel injury, they're unable to feel trauma, they're unable to feel pain, right? So now we have a surrogate marker for the ulcer formation in way of temperature reading, right? So before ulcers develop, ulcer is a traumatic experience to the foot, right? So any trauma causes inflammation. Inflammation, hence, leads to elevated temperature. And if we can pick up elevated temperature, then we can potentially prevent that tissue from breaking down and a full-blown ulcer from occurring.
So talk about the standard protocols that are set for patients who come to the UCSF Limb Preservation Center and Diabetic Foot.
What we do with patients who come to our center is we assess them with a multidisciplinary team. In other words, podiatry, vascular surgery working together at one setting instead of being in silos. Typically what happens is you see a podiatrist, then you get referred to a vascular surgeon or vice versa, and a lot of time is lost. And the advantage of having this multidisciplinary team is that we assess the patient together. We first assess if they have risks of infection, if they have severe vascular disease or arterial disease. Maybe they need vascular intervention. Maybe they need debridement. Maybe they need both. And who goes first? Does vascular surgery intervene first? Does podiatry intervene first? Or do we take this patient together and do a collaborative effort together in one setting? We also assess perfusion. We have non-invasive testing performed at the same time. So it's a one-stop shop. And I think that's really the key to saving limbs, is to have this one-stop shop where we're all under one roof assessing the patient together.
Now, it's not just the question of the cart before the horse, it's a question of which horse is before and which is the cart in each situation. How do you determine whether a patient should be seen by the vascular surgeon versus a podiatric surgeon first?
Well, in our center, we see them together. So we have
right, you see them together, but then, are you going to restore blood flow first, or are you going to focus on the debridement? And I think this is really important for patients to also understand if they're in a different center that doesn't have this multidisciplinary approach, they need to know just by looking at their feet, you know what, I need to maybe go see a podiatric surgeon first for this, and then get my blood flow restored, or vice versa.
Right. So the best way to determine who goes first is to find out if the patient has an infection. If the patient has an active infection in their foot, infection debridement goes first. So that means podiatry needs to get rid of the infection first, and then shortly after, vascular needs to do their intervention. Okay. Now, occasionally that's done together in one setting in the operating room, when we both go into the operating room and we both do our particular intervention at the same time, right? If there is no infection present, vascular usually goes first, improves the blood flow, and then we follow after there's decent perfusion to the foot or better perfusion to the foot, then podiatry follows. And the only time that podiatry goes first is when there's an active infection that needs to be taken care of.
But sometimes you end up with an active infection that is not going to go away unless you have extra perfusion.
Well, yes and no. If there is an active infection absolutely needs to be drained, because if we don't drain the infection, we can lose the foot and the leg because it will travel up the foot and the leg. So we need to stop the infection first. Mm-hmm. And once we stop the infection, shortly after, we need to reperfuse the foot or improve blood flow to the foot. And then we follow up with an appropriate definitive procedure in the foot to try to make it heal.
Okay, when it comes to draining, I'm talking, so once you have it drained and you have it at least managed to where they're on the antibiotics and get that process going, that's really smart. Then go in and perform the intervention.
But I do want to make sure that patients understand that it's really done concurrently almost. It's not 1 week we do this, the following week we do that. We try to do it pretty close and in time, right? Because the more time passes on without adequate perfusion, the more tissue, the more parts of the foot that we lose. Mm-hmm. So I have to make sure that everybody understands that timing is absolutely critical to saving limbs.
What is the timing that is defined by the standard protocols at UCSF and your center in terms of intervention? Do you wait for tissue loss, or do you try to get it before tissue loss to restore that blood flow and vascularize the pedal loop?
Ideally, we try to restore the blood flow before tissue loss. A lot of that depends on when we actually see the patients. So the problem that we encounter is delay in care. Patients usually don't come in time. And that's the goal for us, is to get out to the communities and let people know that the earlier we see them, the more we can save. The more tissue loss, the less we can save.
With such an amazing center, and especially a high-profile center such as the Limb Preservation Center that you have there, I would think that there would be standard protocols that would trickle down all the way to your gatekeepers of health throughout the entire UCSF system, to those primary care physicians, to say, hey, we need to get these patients tested on a regular basis. Everyone over age 50 has to have an ABI, or you need to check the pulses in their feet. And especially if they're diabetic, 1 in 3 diabetics over age 50 has peripheral artery disease or circulation issues and should have an ultrasound every couple years.
Oh, you couldn't be more right. That's really the goal. The goal is to get everybody tested, at least to get their ABIs done. take ankle pressures, maybe toe pressures once a year for patients that are at risk. And at the same time, any diabetic patient should be tested, have their foot evaluated once a year as per ADA guidelines. Unfortunately, that's a struggle, and we continue to fight that battle. We try to educate our gatekeepers. We try to educate our primary care physician, nurses, emergency room personnel, that we want to be called on these patients. We want to assess these patients, not after they have tissue loss or after they develop gangrene or foot ulcers. We want to see them ahead of time so we can put and stratify them, have a risk stratification system, and see who's at high risk, who's at moderate risk, and who's at low risk. Not all diabetic patients get into trouble. Not all PAD patients get into trouble. And it's important to understand that PAD is a spectrum, right? It's a spectrum from mild to severe. And it's not like one day you wake up and you have this severe disease. No, it takes years to develop. And if we can assess and screen these patients appropriately, timely, I believe, and our center believes, that we can save a lot of limbs.
Right. You know, I have a lot of friends with peripheral artery disease who come to me and they say, oh my God, I've gone on to Dr. Google and it says there's a 5-year mortality rate. I was just diagnosed. I'm going to die in 5 years. Like, what are you talking about? I was like, whoa, hold on. You caught it early. There are a lot of new approaches, techniques, and tools and philosophies that are developing every single day. No, there are people that can live a longer, healthier life when it comes to PAD. But getting this across to these gatekeepers, and even I think the endocrinologists, to start checking for this early.
I think that most people don't understand how mortality rate is related to their disease process. And it's important to make sure that patients understand that PAD, or peripheral arterial disease, is the same disease that occurs in the heart. CAD, or coronary artery disease. So if we can pick up PAD early enough, we can also get these patients on appropriate medications, to maybe have the patient see a cardiologist and pick up some heart disease that can be intervened on and appropriately and timely, so we can decrease that mortality rate. So PAD is not the only reason and the main reason why people think and feel that they have this high mortality rate. It's really because of the coronary artery disease, the underlying coronary artery disease that they have. So we have to recognize PAD, we have to assess for CAD, and plug them in appropriately. And again, that leads to early intervention, screening, and then we can decrease not only amputation rates, but also we can decrease mortality rates.
Such an important point you make. 3 in 5 people who suffer a heart attack have peripheral artery disease. And my message is, if only the doctors even took their 2 fingers to check the leg pulses, how many lives would be saved?
Right. And that's a great point. And that's a point that most people just don't understand. If we can only screen their lower extremities, their feet, we can pick up a lot of coronary artery disease as well.
What about this trend towards office-based labs? We have I think about 1,000 here in the United States. Also ASCs, ambulatory surgical centers, that are popping up across the United States, which I think the ASCs are more likely to end up taking the key from what you're doing at UCSF and maybe bringing in a podiatric surgeon on staff to be able to debride and to in the same procedure in the same room as the vascular surgeon or interventionalist ends up revascularizing, let's say, the pedal loop in the foot.
So I think the more collaboration we get, the better it is for the patient. And it's the team approach that's really important. And I think that having more outpatient labs that you talked about really brings more awareness of peripheral arterial disease. And I think that's a good thing. The more awareness we have, the better it is for the patients, the more legs we can save.
I think it's important to send a message to the office-based labs and to the ASCs that if they don't have a close relationship with a nearby podiatrist, they need to get one, for one. And number 2 is, doing a very close coordination to where if they do have a patient that is getting that revascularization, the blood flow restored, that right there and then the nurse gets on the phone with the podiatrist nearby and gets that patient an appointment for that week within a couple of days to make sure the debridement happens.
Right. I think you're alluding to the point that improving blood flow is not the end, right? That's just the beginning. And improving blood flow has a certain limited window. And because we all know that when you put a stent in or you do an angioplasty, eventually there's restenosis that occurs, okay? And there has to be surveillance. And from the podiatry standpoint, we have a fairly limited window before that restenosis occurs to improve the foot or to get that foot healed. And the more time we waste getting that patient into a podiatrist's office or clinic, the worse it is for the patient.
And an important point to bring up is that it's not just toe and flow within your facility, it's toe, flow, and go. What do we then do for that last mile there at home? Because it doesn't just, the debridement, that doesn't just make it heal. There's still home care that needs to be done, and that wound and that state of the wound can actually change overnight with improper care at home. How do we improve? That's the number one complaint I get from a lot of these friends with peripheral artery disease and their non-healing ulcers, that they may have someone come in once a week, but gosh, they do one wrong step, a piece of gauze isn't sterilized, they wrap it too tight, they don't wrap it too tight, tight enough. Like, there are all these factors that can change the game in just seconds. How do we improve that?
Right. We talked about podiatry and vascular being the key players in trying to save the limb. However, there are ancillary team members that we always deal with. For example, home healthcare. Home healthcare is a big part of healing. So we have to be on the same page. Now, the way that we function, now we have a very close relationship with home healthcare agencies and nurses. Patients come see us, let's say, once a week, but then they get to see home healthcare nurse 2 to 3 times a week in addition. So we all need to be on the same page and work in concert together. And that's our big message in our centers. We're all on the same team. It's not just improve blood flow. It's not just do debridement of the foot. It's what happens after the patient leaves our clinic. Okay. We need to close the loop. And that's the message that needs to be out there as well. You have to have these close-knit relationships with all the team players in order to get the patient to the final state, which is a healed wound, and back to ambulation.
And for those that are innovating in this space, those who are researching in this space, where is the white space? What needs to be done to make this standard protocol across not only America, but around the world?
I think we are working with our local societies, with our national societies. We're writing guidelines. We're giving lectures at our conferences, and the word is getting out. I can tell you that in the last 5 years, the multidisciplinary team approaches, such as the one we have at UCSF and such as the one that Dr. Armstrong has in Southern California, they're popping up in more and more places around the country as well as around the world. And nothing is more important than education and outcomes.
Fantastic. Thank you so much, Dr. Reyzelman. And you're teaching that next generation as well of vascular specialists, whether it's podiatric or interventionalists. You're a clinical professor.
Yes. Being at UCSF, there's obviously a lot of teaching. So we have a large team. We have a team of vascular residents, vascular fellows, podiatry residents, podiatry fellows, and as well as podiatry students. And I also teach at the California School of Podiatric Medicine, the upcoming residents.
Thank you so much. And finally, any critical questions that you would suggest that patients ask their doctor, just in general, to ensure they're getting the best care possible for their peripheral artery disease?
I think patients need to understand and intervene in their own care. They need to be in charge of their own care a little bit more than they have been in the past. And they need to be their own ambassadors. So having a foot check, having their shoes removed, having their pulses checked is a must by the primary care. And if the primary care is too busy, we're happy to see these patients. We're happy to screen them. And we have a policy that we see these patients pretty much within 24 to 48 hours. So it's not an issue of access to care from our standpoint at UCSF. We get the patients in right away. We just want to make sure that these patients get to see us.